Okay. Thanks, Guillermo. While they're going to load automatically. Okay, perfect. So I'm going to speak first to those across the country to say my case is an appetizer to what's coming on October 27th. When I chose this case, I thought, well, it'll be kind of interesting that I'm a neuro IR by training, by fellowship. And my partner, after I picked the case, said, you are aware that October 27th, SIR is doing a webinar on middle meningeal artery embolization. And I said, okay, perfect. So I'll try to keep mine very brief. And the other thing that I'll say to those of you across the country who are watching and listening, you may or may not be aware that SIR has a committee that is working towards IR involvement in stroke. And I say that to those who are interested in stroke. I am a member of SNIS, and I'm also a member of SIR. And my partner, who is an IR by training, a neuro IR by training, he does stroke. When he joined me, we are at a comprehensive stroke center. For call purposes, he had to learn to do stroke, and he was on board and I was on board, and I'm very proud of our stroke program. And I know that there are some IRs across the country who have an interest in neuro and have an interest in stroke. And there are those of us who are on both sides of the SNIS and SIR who believe in IR's role in stroke. And there is a committee within SIR that is working on that. And I'm on that committee. I'm only a small portion. I don't claim any responsibility for their work because I just joined recently. But to those of you out there who have an interest in stroke, don't lose interest. It is a huge part of IR's future, as I think my case, which is management of chronic subdural hematomas and middle meningeal artery embolization. So again, if you're really interested in middle meningeal artery embolization, coincidentally, October 27th is for me and for you, because I think there's going to be a lot to be learned on this particular subject. So this particular case is an 87-year-old who most of the middle meningeal artery embolizations I do, they come to me as true chronic subdural hematomas that are weeks or months out from recurrent subdurals. And usually the neurosurgeons will contact me and say, we really think this guy needs embolization. He's not going to tolerate it. A third, fourth subdural hematoma. Unfortunately, this particular case came to me as, here's a guy with another acute on chronic subdural. This is his third time. He's 87 years old, and the neurosurgeon was banging on my door saying, I want him emboed right now, which I initially had great reluctance to, because as this has sort of been a growing, burgeoning field, it's all been about management of chronic subdurals to reduce recurrence. But in this particular case, the family actually read up on management of subdurals, of middle meningeal artery embolization. This 87-year-old was sharp as a tack, was still living his best life and wanted something done. And so we agreed. And so the first image on the left shows that he actually has an acute on chronic subdural. So I said, first of all, he's got a little midline shift, talked to the neurosurgeon, they drained him. And I started diving into the literature, and I found that middle meningeal artery embolization was originally used as sort of a adjunct to operative failure, people that really couldn't be managed operatively or in a early post-op setting. So there actually were reports in literature of using this middle meningeal artery embolization soon post-op for people that the clinicians felt weren't going to tolerate it again. So the field generally is for chronic subdurals, but in this case, I got wrangled into managing somebody with an acute on chronic. So to be clear, the neurosurgeons drained him, and about 3-4 days post-op, while he's still in house, they took the drain out, and he then came to me for embolization. So we'll do a quick anatomy dive. So neuroanatomy, and I'll kind of briefly talk about the chronic part. So how do you define when a subdural is chronic? Again, this is information I looked up in the literature when I was debating about doing this case. And it was initially said that maybe over 2 weeks post symptom onset, you can call it chronic. And then a more recent definition was if you have greater than 50% hypo to isodensity in the subdural, that, okay, that is a definition as chronic. And throughout our medical education and medical school, we were taught that chronic subdurals were mainly thought of as a low flow fluid accumulation with venous origin. And then when it's acute, it was tearing of the bridging veins and you get the acute blood accumulating in the subdural. But there's information in literature to suggest that that's not all there is to it, and that there is a inflammatory response and proliferatory response that occur along these dural cells that are there obviously on the lining on the dura, and that you get into this cascade of inflammatory response and fibrogenesis, which then leads to angiogenesis and this damaged dural layer that's in a constant state of repair, damage, and that the fluid then accumulates, and that's why you have some patients who get chronic subdural hemorrhage, back again chronic subdural, and this constant inflammatory cascade and angiogenesis, and that there's that additional role explaining why they recur. So this is the AP and lateral angiograms before getting ready to embolize. And so this is an external carotid artery injection. You see the faint outline of the internal carotid artery here. This is due to my being a little bit too brisk with my injection. There was not a collateral there between the external carotid artery and internal carotid artery. That was just me being a little bit brisk in the injection. So unfortunately, I wasn't doing this angiogram thinking I was going to present it, and I perfectly overlapped the middle meningeal artery and the superficial temporal artery. So if you remember, the middle meningeal artery comes up and hits the foramen spinosum and then makes this abrupt anterolateral turn. And so that's the middle meningeal right there. This is superficial temporal artery coming up there. Again, IMAX here, and superficial temporal artery and middle meningeal artery. So I show those two things to bring up one of the dreaded risks and complications of middle meningeal artery embolization, which are the collaterals that do exist between the internal carotid artery and the ophthalmic artery in the eye. And every single time I get consent for one of these, I bring up risk of stroke and risk of blindness. And for those of you across the country, if you talk to your colleagues, it's happened. There are cases out there where people have done middle meningeal artery and there have been strokes and there have been blindness. And I'm not at all suggesting that's the fault of skill of the operators. I'm suggesting that there can be tiny unseen collaterals between the internal carotid artery and the middle meningeal artery, or the ophthalmic artery and the middle meningeal artery. And they're well-known, discussed in the literature, reported. And so when you're doing your injections, that's one of the big things you're looking for, are those collaterals. And there was actually a poster presentation at the stroke conference this past year where one site, they talked about selecting the middle meningeal artery and then injecting nitroglycerin to dilate the artery, and then looking for the collateral between the ophthalmic and the middle meningeal artery, and then coiling it off, sort of the Y90, and you're coiling the GDA before, which I don't do Y90, but it's similar in the sense that you're coiling off that collateral to prevent inadvertent non-collateral embolization, which is the dreaded complication of middle meningeal artery embolization. So the middle meningeal artery divides into multiple branches. I'm not going to bore you with all the anatomy, but suffice it to say, you then do a selective microcatheter angiogram of the middle meningeal artery. And then once you've achieved your position and ensured that there's no collaterals existing between your catheter position and the internal carotid or the ophthalmic, proceed with embolization. So I think of middle meningeal artery embolization as a little bit like the wild, wild west, in the sense that there are a whole bunch of different options and nobody knows at the moment exactly what is the right embolic. And I think that you'll find some people who say I'm PVA all the time, that's what I use. And then you'll find people who say I use onyx. And then I actually read that there's people who are mixing onyx and a thiodol and using that. And then there's some people who are using embospheres. And there are research studies going on right now to decide what is the right embolic. I think that my gut says in the end, it's going to be that any of these embolics are a reasonable choice if used properly, but I don't know. I don't know where it's going to end up. But I'd say probably a lot of people are using PVA. I personally use a lot of Onyx for other things. So I use, NBCA, I left it out. There's other people using NBCA. There's probably some other embolic I haven't mentioned that there's reports in the literature of people using it. But anyways, so I used Onyx, and this is actually just the fluoro store showing the Onyx in the middle meningeal and going all the way out to the dura. And you can actually see the Onyx along the dura on the AP and the lateral. You can see the Onyx there along the dura. You can see he's recently post-op from them removing the drain. He still has the staples on his scalp. Again, I like Onyx because when you're doing embolizations like this, it is obviously highly visible. You will get distal penetration, but there's upsides and downsides to each of the embolic, which all of you are familiar with from doing other embolizations. So this is just a post-op, post-embolization. You still see the superficial temporal artery. You don't see the middle meningeal anymore, and you can see the cast of Onyx there post-embolization. So he did great. So despite my reluctance, feeling like it maybe wasn't the perfect time to do it, the patient did great. He actually went home the next day. I followed up with him weeks post-op. He's doing great. He hasn't had a recurrence. So like many things in IR, sometimes you get in a situation where you're saying, am I certain this is the right time for this or not? But nonetheless, he's recovered and doing great. So questions? If there are questions about the MMA EMBO from the country, the people that are watching, I'm happy to do it. If there's questions about the politics of IRs doing stroke, let's leave that for a different night.
Hello. So no questions about MMA EMBO, but they're pretty amazed with what you're doing here. So that's a good thing. One of the questions they're asking is, how do you get stroke certified?
Oh boy, so that was a long process. Well, so you're asking me individually. So I did a neuro-IR fellowship. So I was stroke certified through my fellowship. But my partner, when he joined me, there was back then a little less politics or scrutiny, if you will. And so truth, my partners know this, I took 24/7 call with my partner for over a year and did every single case with him until he had done enough that I said, you're good to go. It was a long year and 3 months that we did stroke together. As far as where that stands today, there are a number of us through SIR who think that there should be a pathway to doing stroke for IRs coming out of fellowship. And, you know, I don't have a definite answer as to how it takes place. Maybe it's partnerships between neuro-IR fellowships and body IR fellowships, allowing some fellows to cross over and get certified to do stroke. Personally, again, I'm going out on a limb because I run the risk that there'll be neuro-IRs who are offended by this. But personally, I think that those who want to do it, you guys have the catheter and wire skills. It's no different, your skill set. It's just that you spend the time doing neuro versus you spend the time doing body. So I would say that all of us, you who train, should talk to your neuro-IR colleagues and say, hey, is there a role for a body IR fellow to spend time doing stroke with the neuro-IRs in fellowship and get people certified to do stroke? Or the SIR committee that I'm on, working towards finding a pathway through virtual cases and proctored cases, which this is something that this SIR committee, whether you know it or not, there are people behind the scenes way more connected than I, who are working on finding pathways for virtual cases and proctored cases, and even a virtual proctoring for people to do stroke. I really think it's the future, because I'm taking up too much time, but anyways, there was a time when the cardiologist came to me when I was training my partner and said, we can do it. This is truth. I'm not making this up. They said, we can do it. And that's not reasonable, right? So it's best that we all get involved.
I mean, they want to do a PAE, so, I mean, they want to do everything.
Right.
But we'll leave that, we'll leave that
I know,
aside.
sorry, I've got too far into the
But I think the other
politics.
thing that people spoke about, for the audience and people here was SIR has a stroke course. I think it's usually on a Wednesday or Thursday of every SIR conference. That is very useful. I went to it 3 years ago. I didn't make much out of it, but it's a good course.
At the end of this year's SIR, there will be a dedicated day and a half to stroke at the end of this year's SIR.
I think that's all good conversation. Thank you, Dr. Bina.
Thanks.
Thank you.